Here we are again, at last, for our... Welcome, welcome, welcome to our Darwin Day lecture, to all our guests, both in person with us in the hall and online. My name is Andrew Copson, I'm Chief Executive of Humanist UK, and it's my job this evening to detain you very briefly to speak a little about Humanist UK and the Darwin Day lecture as a whole, before I pass over to Alice Roberts, who's our chair for this evening. It's great to be here in person tonight in Conway Hall, the historic home of humanism. It was in Conway Hall almost 20 years ago in 2003 that we held our first ever Darwin Day lecture, and former speakers at the Darwin Day lecture and recipients of the Darwin Medal include Eugenie Scott, Adam Rutherford, Chris Packham, Sir David King, and of course Alice Roberts herself, who now chairs the lecture series. In pre-COVID years, the Darwin Day lecture involved 1,000 people crammed closely and sweatily together in a small space in a single evening with drinks before and afterwards. That's what life was like then. But mindful of the ongoing pandemic, and the theme of tonight's lecture reminds us of that, we've been careful not to be quite so bold as that, with extra precautions taken to ensure everyone's safety. But I'm pleased to say that there are 1,000 people listening to the Darwin Day lecture this evening, but 800 of them are online. Hello to the people, to the immaterial ones, which is not a line that's ever passed lips at a humanist event before. But if we could all just hold in our thoughts for a moment those who are out there somewhere, we're very glad to have them with us. Whether you're watching from home or attending in person, do tweet along. We're using the hashtags #DarwinDayLecture and #DarwinDay. And now please allow me to introduce our chair for the evening and for the Darwin Day lecture series, our president, Professor Alice Roberts.
Thank you very much indeed, Andrew, and welcome everybody to Darwin Day 2022. It's our first in-person Darwin Day event for a couple of years, and it does feel brilliant to be getting back to live meetings like this and seeing people. But perhaps we've also learnt something over the last couple of years. It's amazing to be welcoming people joining us online as well, and I think that will continue into the future. Now, the Darwin Day lecture is about exploring humanism and humanist thought, in particular with relation to science, and in particular, of course, with relation to evolution. Charles Darwin and his works, and the Darwin Day speaker and medalist, has made a significant contribution in one of these fields, and tonight it is about evolution of pathogens. We're celebrating the annual global celebration of the birth of Charles Darwin, and in fact what we're doing is celebrating that tomorrow, so we're just ahead of actual Darwin Day. But we are also tonight celebrating the International Day of Women and Girls in Science, so it's very apt indeed that I am introducing a really fantastic female scientist, Professor Dame Anne Johnson. Now, Professor Dame Anne Johnson is Professor of Infectious Disease Epidemiology, and she's the co-director of the Health of the Public at the University College of London, UCL. She's led an extremely distinguished career in epidemiology, something we've actually heard of now, and public health, focusing on topics including HIV/AIDS, in particular spending many years of her career researching HIV/AIDS, other sexually transmitted infections, influenza, and diagnostics for infectious diseases as well. She joined Middlesex Hospital Medical School at the start of the 1980s HIV epidemic, and then subsequently directed the Medical Research Council UK Centre for coordinating epidemiological studies of HIV/AIDS. In 1990, she was funded to complete the UK's first national survey of sexual attitudes and lifestyles by the Wellcome Trust, and that work has since been repeated every 10 years and continues to inform key policies on sexual health around the world. She's a member of the Royal Society's Data Evaluation and Learning for Viral Epidemics, DELV, group. She's a member of the SAGE Transmission subgroup, and she's chair of the UK Committee for Strategic Coordination of Health of the Public Research Shopper. She became president of the Academy of Medical Sciences in December 2020. So without further ado, Dame Anne Johnson, I invite you to give your Darwin Day lecture.
Well, good evening, everybody. It's an immense pleasure to be with you today, and thank you very much for the invitation and the honour of speaking to you today on the topic of people and pathogens. Well, infectious disease outbreaks and epidemics have been shaped by the evolution of human society and in turn have shaped human history. In this interplay, infections have evolved and human societies have adapted. In this lecture, I'm going to focus on the environments in which infections emerge and the interplay between biology and behaviour and the public health interventions we put in to control spread. So just to remind everybody that we live surrounded by a wide range of microbes and only a small fraction of them cause human disease. Many of them, in fact, are beneficial. So the microbiome in the gut has 39 trillion microbes and bacteria, virus and fungi. Without them, we couldn't survive. We need them to digest our food, and they may protect us from harmful infections. We depend on yeasts for the bread we eat and for the wine we drink. And the infections that cause human disease we call pathogens. Many of the infections that cause outbreaks initially emerge from animal or environmental sources. And those animal sources include livestock and wildlife as infections emerge. And the result is interaction between human populations and animals. And here's a list of some of the historical pandemics and outbreaks. There are a series of epidemics due to the bacterium Yersinia pestis, which is transmitted through the vector of fleas, which are initially becoming infected with Yersinia via wild rodents. And then, of course, there's 5 successive cholera pandemics caused by Vibrio cholera, a bacterium transmitted through contaminated water. And then there are successive pandemics of influenza recorded through history. But we didn't actually discover the influenza virus until the 1930s. Many of those have been linked to avian sources and most recently to transmission from pigs. Now, HIV and AIDS, which I'll talk about, emerged from populations, from chimpanzee populations, and the 3 coronaviruses which have emerged in the last years of this century again have emerged from animal sources. But I'm going to focus on 3 infections I've worked on through my life: HIV, influenza, and SARS-CoV-2, the virus causing COVID-19. So if we think about what drives the incidence of infection in the population, we have to consider the biology of the organism and the pathogen, the biology of the host which is affected. In addition, we have to consider the behaviour of populations in which these infections take place. In addition, we have to remember that our behaviour and our biology is also affected by the socioeconomic and physical environment in which we live. And so epidemics emerge when they can fit when a pathogen can fit in an ecological niche in which the conditions are suitable for its survival. So it follows that the control programs which we put in place are those which need to impact both on the behaviour of populations and the biology of organisms. So the success of an organism depends, first of all, on many aspects of its biology. Its infectivity, how easily it can be transmitted and by what route, for example, through coughing and sneezing, through sexual contact, through water. And then what is the infectious period of the disease? How long is it infectious for? How long is its incubation period from somebody becoming infected and becoming ill? And that's important because if we have a long incubation period when someone has no symptoms, an infection can be passed on silently, so much a feature of our current pandemic. And once the infection affects a host, it has to survive, but it also causes a variety of symptoms. And that, again, will determine the impact it has in public health terms and our response as human beings. Can the infection survive outside the host? How good is it at crossing species from animals to humans? And what is its genotype? How fast does it mutate? All things we've had to learn about during the recent pandemic. In turn, the host has its own defences against pathogens. Our genotype, some of us may be protected from some infections. There are examples in HIV. We have physical barriers to infections such as our skin. We have the mucosal immunity of our respiratory tract and our guts to protect us from invasive infections, and our immune response both at the mucosal surfaces, like in our nose and respiratory tract, but also in the cells of our blood. Our nutritional status and, for example, immune suppression may affect our susceptibility to disease, and our microbiome may protect us. And at a population level, once an infection enters a population, we build up immunity to it. And that we consider is part of the protection that builds up, sometimes referred to as herd immunity, although that only occurs when you get usually very high levels of immunity in a population. And all these factors will determine whether an infection lives without causing disease in a population or is pathogenic and causes disease. And in terms of behavioural and environmental drivers of transmission, we have to consider socio-economic conditions like housing, the availability of clean water. We have to think about contact rates, which are critical to the transmission of infection, and population density is very important, so that in fact as human beings it was only when we began to live together in large numbers that we could get human-to-human transmission of many of the infections we're familiar with today. And our interaction with other species and our sexual behaviours, all these factors determine whether or not an infection will be transmitted. And I think all of us have now become familiar with the armamentarium of control programmes which we have in our hands to control infectious diseases. We've seen this through the pandemic, early detection and surveillance, widespread screening. I know you've all been asked, for example, to test this evening. Behavioural interventions, you've all got your masks on. Treatment, which reduces infectivity and shortens the infectious period. Quarantining and social distancing have become an everyday phenomenon in our lives, unfortunately, through the pandemic. Contact tracing to identify early cases, vaccines to build immunity are all important, and alongside that, the built-in natural environment to alter the ecological niche. Now, I'm going to turn to my first topic, and this is the first account. I don't know how many of you will recognise, but this was published in the MMWR in the States, in the United States in June 1981. And it describes a cluster of 5 young men, all of whom had an unusual pneumonia, pneumocystis carinii pneumonia, who had been identified through an early epidemiological investigation with a pneumonia that only normally occurs in people who are immunocompromised. That early detective work by epidemiologists showed that they all had in common a history of having had a homosexual lifestyle, and the suggestion was that this might be a disease acquired through sexual contact and resulting in immunodeficiency. Now, I think now you'll recognise that this was the first description of what turned out to be a pandemic, the AIDS pandemic. Indeed, it was only yesterday that Luc Montagnier, who with a wonderful female scientist, Françoise Barré-Senoussi, yesterday it was reported that Luc Montagnier had died. And it was he, of course, who 2 years after this, along with Françoise Barré-Senoussi, made the first identification of the virus that caused AIDS, HIV. And AIDS entered into the population, stimulating fear, stigma, and indeed a great deal of prejudice against those who suffered from it. Really, we only had behavioural interventions at the start of that epidemic. There you can see the Chris Whitty of his day, Sir Donald Atchison, then CMO, who was very, very involved in the UK response. But we knew so little about this infection. There was great fear of contagion. You can see there a well-known photograph of Princess Diana opening a ward that I was involved in planning in the 1980s. And this was a very important moment in beginning to dispel both fear of casual infection, but also to overcome the immense stigma that was addressed to people who really had terrible survival at that time because there were just no treatments. And you can see there the hope that a cure would be found within 5 years, which of course 40 years on it hasn't been, even though now we have very much better antiretroviral treatments which can reduce disease, but not actually completely rid us of the virus. And it became evident too that this was a disease which was also emerging as an epidemic in sub-Saharan Africa. And we relied, as you can see, on behavioural interventions, and the AIDS leaflets, you may remember, Don't Die of Ignorance, which don't really mention how HIV was transmitted. So if we want to think about how an sexually transmitted infection can survive in a population, we can think of an infection being introduced at the beginning to an entirely susceptible population. And we think of the R number. You might like to remember, I'm sure you've seen that being reported on the television each week, but for the COVID epidemic, but we can define it as the average number of new infections transmitted by an infected person during the infectious period in a susceptible population. And a simple model for a sexually transmitted infection, and I promise you this is the only equation, and it isn't a difficult one, is we can think of the basic reproduction number depending on first the probability of transmission of an infection, how easy is it to pass an infection on, the effective rate of partner change, and the duration of infectiousness. So what was the ecological niche that facilitated the HIV epidemic globally? Well, first of all, it was biology. It could be transmitted only through sexual contact and blood. So HIV had a low transmissibility, a low value of beta. It could only spread sexually with sufficient rate of partner change in the population. Well, of course, that's difficult too, because we have many fewer sexual partners than we have social contacts. And so a virus that's sexually transmitted had to hang around until the next partner turns up. Now, to do that as a sexually transmitted disease, it's a very good idea to have the characteristics of being asymptomatic, since it's not evident to a human being that the virus is present, and a long incubation period is absolutely required in the case of HIV of months and years in order for sufficient transmission to be maintained for such an infection to survive in a human population. And actually that's exactly what HIV had, and that was what created a hidden epidemic. It was only years after the identification of the first cases that it was recognized how much the virus has spread because of asymptomatic infection. And then HIV also had this characteristic of attacking the host immune system, therefore getting around the neutralizing antibodies we normally produce. So from an individual behavioral point of view, we should remember that many behaviours that facilitated the spread of HIV were increasing. There was sharing of injecting equipment, both for medical reasons and for recreational drug use. Blood and blood products became contaminated and HIV could be transmitted that way. Sexual behaviour, as I'll show you, was changing, and there were concomitant sexually transmitted infections which disrupted the genital mucosa, allowing HIV to be transmitted more efficiently. And then around the world were those socioeconomic drivers I mentioned: rural-urban migration, travel, changing employment practices such as the mines in parts of Africa, which took men away from women and therefore developed new economic drivers of commercial sex, and changing family structures. So let's look at what was happening to sexually transmitted infections in the UK. What was the ecological niche that occurred in the UK? Well, we have surveillance of 100 years of numbers of cases of gonorrhea in the UK, which is shown in this slide. And you can see that's a very unusual kind of graph. It tells the social history of the century, really. You can see that during the 20th century, there were 2 world wars, and there were increased rates of gonorrhea at those times, and again during the Second World War related to changes in sexual behaviour. And then after a dip after the Second World War, infection rates went up enormously. Now, of course, there were legislative changes, but there were rises in gonorrhea well before, for example, the Abortion Law Reform Act, the decriminalisation of homosexuality, or the availability of the oral contraceptive pill. And if we look at the preventive interventions we had in our toolboxes from a public health point of view, well, during the First World War, the only thing that was available was chemical prophylaxis. During the Second World War, the use of condoms, and then, of course, the widespread availability of penicillin, to which gonorrhea was completely susceptible. So a biological intervention. So we might have hoped that gonorrhea with this magic bullet would go away, but it didn't. The rates went up all the way through the 1970s until, surprisingly, they came crashing down around the 1980s to lower levels than the rest of the century. Now, as I'll show you, this all can be attributable to the extraordinary changes in behaviour which resulted during the advent of AIDS. And you'll see again the rising rates following 1995, when antiretroviral treatments became available. So human beings adapted to this epidemic through behavioural change, which did a great deal to control it. Of course, we knew very little when you go back to that equation of the transmission of sexually transmitted agents about the behaviour of the population. And it was in 1990 that we had our first national survey of sexual attitudes and lifestyle funded, which has already been mentioned. And here are the 3 decennial surveys, which overall have interviewed around 40,000 people. And these were random samples of the population. And they showed something about the ecological niche that HIV had entered. Sexual behaviour had changed dramatically. The age at first sexual intercourse had declined in men and women. The age at first cohabitation or marriage had increased over the same time as had the age of first childbirth. Over the same time, in both men and women, there was evidence that the number of sexual partners, lifetime sexual partners, was increasing. So the proportion with 10 or more heterosexual partners in their lifetime had increased quite markedly. But look how behaviour changed in 1981, and this is just quite a snapshot of what happened. Condom use became very common practice after 1981, and this is the proportion of people reporting condom use at first sex by the year of first intercourse, and we can track that right back to the appearance of the epidemic. So behaviour changed, and it changed in a range of different populations. It wasn't until 1985, really 4 years after the first description of AIDS, that we had reliable antibody tests to identify who in the population had been exposed to HIV. These weren't people who had AIDS. These were people. This was an anonymised survey of men who had sex with men who were attending the Middlesex clinic in London between 1982 to 1988. And there you can see the silent epidemic I was referring to. Between 1982 and 1984, the prevalence of anti-HIV antibody rose from under 5% to over 20%, a massive incidence of 10% per annum. But then it flattened off. It didn't go on rising, thank goodness, because of the efforts of the gay community to get the word out, change behaviour, gonorrhea rates came down, and incidence of HIV declined. However, in the following years, I showed you before that gonorrhea rates went up again suggesting changes in behaviour. And interestingly, combination antiretroviral therapy became available from 1995, 10 years. Think how different a time course this is from what we've been seeing in this pandemic. But 10 years it took to the availability of effective combination antiretroviral therapy. And that did 2 things to change the biology. First of all, it greatly reduced the incidence of disease and of AIDS. Thank goodness. People could live more or less a normal lifespan with their virus suppressed with antiretroviral therapy. Even better, the antiretroviral therapy in suppressing the virus also meant that people became virtually uninfectious, 96% reduction in the risk of transmitting the virus, as you can see from that trial. But in this graph, you can see that in the blue bars, this shows the declining. Something's happened to. I think you can see it on. Something's happened to the slide. But basically, let me explain that the blue bars show the rates of undiagnosed HIV infection, which were declining. But despite more people getting on treatment, in the red line you can see the modelled incidence of HIV. So even though we had a biological intervention, which should have brought down incidence, it remains stubbornly the same. And here we see the balance between biology and behaviour. People, as human beings, had adapted. Naturally, there was lower risk, and so risk behaviour in turn reverted, and people who were undiagnosed or between becoming infected and becoming diagnosed were still at risk of transmitting infection. And we were able to show in community studies of men who have sex with men that over time the rates of unprotected anal sex were increasing, as were amongst those who were at risk of transmitting infection were, back to the equation, the C, the number of sexual partners was increasing. And we got this equilibrium between in biology and behaviour to maintain a constant incidence. So where did pandemic HIV come from? Because I've been talking about the UK, but meanwhile there was a major pandemic around the world. And we now know, with the molecular tools which we have in our hands, which were not available back in the 1980s, this is a paper from 2014, that HIV emerged from chimpanzees probably much, much longer ago than we might have imagined. It's now thought that the common ancestor between the simian immunodeficiency viruses, which were closely related to pandemic HIV, and that there was an emergence from those populations into human populations, goes right back to 1920. But only one group caused the pandemic. This is Group M. And the way that was done is that although we only first identified AIDS in 1981, it was found that the two HIV sequences were retrospectively recovered from blood collected in Kinshasa in 1959-1960, and the molecular clock analysis was used to figure out that probably the common ancestors was back in the early part of the 20th century, and this has remained at a low level until in around about the 1960s, probably there was transmission of subgroup B into Haiti, then on into the United States and around the world. And so it is through these molecular techniques that we have begun to understand the evolution of the viruses. But with antiretroviral therapies in our hands, the virus has also fought back. And here, in evolutionary terms, is the evolutionary pressure put on the virus by the antiretrovirals we've been using. And this graph shows in every continent of the world the rising rates of HIV, of pre-treatment HIV resistance. So these are people recently infected, but before they're treated, and there is evidence in their virus of having resistance to antiretrovirals. So this in turn places us with another biological challenge from the virus. But for now, 40 years on from the start of this pandemic, we're making great progress. There's been no magic bullet. We've needed combined biological and behavioural interventions. But the rate of new infections around the world has declined 23% since 2010, as has the change in AIDS-related deaths since 2010. And at World AIDS Day, just in December last year, you can see this call to end inequalities in access to treatment and prevention, to end AIDS through the availability of antiretroviral therapy, and to end pandemics. That's a big challenge. There are still questions. We still don't have a vaccine for HIV. We still don't fully understand, for example, the mucosal immunology of how HIV is transmitted. And we have a challenge in whether we can not necessarily eradicate the virus, but certainly eradicate its consequences in disease. Now, let's try to turn to a different form of transmission, a different route of transmission. Coughs and sneezes spread diseases easily. Here's a nice case. This is a case we're all familiar with, measles. And here's an example of a virus which behaves in a completely different way. Measles was first described in the 10th century, originated from cattle. It's transmitted by coughing and sneezing and is one of the most infectious viruses known to date. It is facilitated, historically by the growth of human populations and travel between them, and can cause devastating outbreak when introduced in unexposed susceptible populations. Unlike, we know, for example, for SARS-CoV-2, measles gives lifelong immunity. And as such, it can only be sustained as an endemic infection in populations which were sufficiently big enough, probably around about over 250,000 people, by continuous, because the adults become immune, having been infected themselves in childhood, it can only be sustained by the continuous introduction of susceptible people into the population, largely birth of children. So it's become largely a disease of children in populations where transmission is endemic. And it used to cause millions of deaths around the world and cause outbreaks every couple of years. But vaccination was introduced worldwide in 1963, but we still have thousands, 140,000 estimated deaths from measles, mainly in children. So we think of measles as a disease in childhood, and many of you in the audience may have actually been born before the measles vaccination program and remember it as a nasty disease of childhood. But we were born into societies where measles had been endemic for years. Look how differently an infection behaves when it occurs in an entirely susceptible population. This is a fascinating story that goes back to 1846. And of course, it was the observations of a Danish doctor called Thomas Panum. And he observed an epidemic of measles on the Faroe Islands. The Faroe Islands are that dot in the Atlantic. They're on the shipping forecast, and they are a very remote archipelago. And in remote archipelagos, of course, in island populations can be very informative about evolution, which of course Charles Darwin knew very well. And in this remote, dispersed island community, they had great longevity, and Panum noted that they didn't suffer from many of the diseases that are observed in urban populations. They'd had no measles case for 65 years, everyone was susceptible, and there was an imported case from Copenhagen. And then 80% of the people on these islands became infected. And Panum carefully recorded the mortality rate in the pre-epidemic period and the year of the epidemic. And his calculations in 11ths, which I think is quite pleasing, instead of in decimal points, are in that box on the right. And what he showed was that in those under 1 year, in babies and things, the mortality rate was 2 9/11 higher than in the pre-epidemic years. But then there was no excess mortality in those between 10 and 20, so the young adults were relatively spared. But then mortality increased up into those aged 65, demonstrating that how differently an infection will behave in an entirely newly susceptible population, such as we are in relation to SARS-CoV-2 now, than it does when you have got endemic transmission. But fascinatingly, he showed that those over 65 didn't have a higher mortality, and indeed there were no cases of infection in those who had been around during the previous outbreak 65 years ago because they had built immunity. And here he began to contest the notion of miasma as the cause of infectious diseases, which was thought in those days, and gave support to the newly emerging germ theory. Now, another infectious disease which we'll turn to is flu. This is the flu pandemic of 1918-19, caused tens of millions of infections around the world. And there's a fascinating book by Laura Spinney called Pale Rider about that epidemic. And as she says, what the Spanish flu taught us is that another flu pandemic is inevitable, but whether it kills 10 million or 100 million will be determined by the world in which it emerges. And she wrote that in 2017, and I think there are messages there for what was to happen 2 years later. So in 1918-19, there were no antivirals, there was no vaccines, indeed the cause was not known. And there were the same debates about social distancing, about mask wearing, And there were no effective medicines, despite the claims in this advert, which, in fact, the active ingredient in many of those cough medicines of the day was actually opium, which is quite good for a cough, but doesn't cure flu. So let me tell you about the influenza virion. Here it is. It has a core of ribonucleic acid, and on its surface it has proteins, the hemagglutinin, by which the virus attaches itself to the cell, and the spike, the neuraminidase spike, which helps to release newly formed virions from the cells in which they're produced, the human cells. And we produce antibodies to H, the hemagglutinin, and N, the spike, and we tend to classify flu infections by those H and N proteins. And to remind you what flu is, most of you have had it. In fact, probably all of you have had it at some time, whether or not you knew it, but I shall tell you about that later. It's an acute virus disease of the respiratory tract with 3 types, and it's type A, which usually causes widespread epidemics. And each year, the timing and extent of disease varies quite dramatically. And why does it vary so much? Well, let's think about populations. Something's happened, and the slide isn't moving forward. There it is. Okay. So flu results in changing severity of outbreaks as the virus changes due to antigenic shift and antigenic drift. Now, antigenic shift means, generally, that 2 viruses become combined, 2 different viruses in the host cell, human cell, resulting in the emergence of a 3rd virus, which we can call virus 3, and that's shifted a new virus. Antigenic drift results from the accumulation of mutations over time, so we get a virus that is sufficiently different but hasn't resulted from combination of 2 viruses. And we now know what has been the evolution of the viruses in human populations over the last century. So the Spanish flu, and this might interest Alice because it's a result of studying burials from the permafrost, that the H1N1 virus causing the Spanish flu was identified. And that then resulted in a reassortment in 1957, causing the Asian flu pandemic caused by H2N2. That persisted through to 1968, when there was another reassortment, and we saw the Hong Kong flu. And then after that, we saw the H3N2 after the Hong Kong. The H3N2 was the Hong Kong flu. And then we come to 2009, where we see a further reassortment, and you will remember, I think, the swine flu epidemic of 2009, pandemic, in fact, which was caused by a new H1N1, a reassortment between human and swine flus. Now, if we think about how this works, how these pandemics work in the population, and why we see pandemics followed by seasonal flu, we can think about this in theoretical terms. I'm sorry, this is a bit of a busy slide, but if I can take you through it. If you look over to the left, we can imagine the introduction of a new virus. A hypothetical, we'll call it an A2 virus. We have low immunity to it in the population because it's new, and a pandemic emerges. We develop immunity to that, and then in subsequent years, we'll see epidemic outbreaks varied in time, but generally of diminishing magnitude as the amount of immunity in the population rises. And that virus, A2, will probably be making minor variations over time, and the waves of epidemics may or may not be associated with those variants. But then, for whatever reason, we probably see an antigenic shift and the introduction of a hypothetical A3 major new variant and into a less immune population, and we see another pandemic, and so the cycle goes on. Now, I had the opportunity with a colleague, Andrew Hayward, at UCL, to study both the burden and severity of both seasonal and pandemic flu in the Flu Watch study. Fortunately, that study was already running prior to the 2009 swine flu outbreak, which you may remember was first described in Mexico, when there were a series of very sick young people infected by this new H1N1 virus. But we were able to compare the outcomes in terms of clinical infection rates and clinical disease in the pre-pandemic and pandemic period. And this is what we did. There were thousands of people recruited from the community into these cohort studies, and between 2006 to 2010 we were able to study them. We took blood from them before the winter flu season each year and after the winter flu season in the following year to compare the amount of antibody to flu that they had in their blood, and we were able to do that through the three seasonal flu outbreaks and then in the pandemic outbreaks in 2009 and 2010. And the results we got told us a rather different story about the one about flu that we probably had in our own minds. That in fact there was a clinical iceberg of flu, that a lot of flu caused only asymptomatic infection, some caused symptomatic infection but not bad enough to go to the doctor, and a very small proportion ever reached hospital, and indeed probably a small proportion was ever reported in the statistics. And of course we don't have anything like the level of testing and so on that we've become familiar with the COVID-19 epidemic. And what we were able to show was that based on a fourfold titer rises in the antibody levels in people, on average 18% of people, of unvaccinated people, had clearly been infected by flu each winter. But 70% of the infections were completely asymptomatic. People didn't know they'd had flu at all. 25% of infections had PCR-confirmed disease, and only 17% of those with confirmed disease had medically attended illness. And surprisingly, there was no more disease in the pandemic than the seasonal influenza years, and indeed the pandemic years had produced less disease, people had less severe symptoms than during the seasonal years, demonstrating that even though you have a new virus in the population or a new variant doesn't necessarily mean you'll see more severe disease in the pandemic setting for flu. And on top of that, we were able to show by studying people's T cells, that's not just the cells that produce your antibodies, but the T cells who give you a further form of immunity from cellular immunity, that they were having an additional effect on top of the antibodies. So we discovered that people who had good T cell responses were much less likely to have confirmed flu during the pandemic, and they were protected against respiratory illness to a substantial extent to both seasonal and pandemic influenza, really making it clear that in flu infection, it wasn't just our antibody response, but actually this broader T-cell immunity that was important. And the same sort of observations are also, of course, beginning to be made during the COVID pandemic. So we really need these sort of large-scale studies to understand the true population transmission dynamics and the evolution of infections and the evolution of our response if we're going to fully understand epidemiology. And we need the kind of studies of viral strain to be going on, which are now available around the world. And we have new opportunities for cross-strain vaccines. Now we understand more about the immunology. Now, before I turn to COVID-19, let me give you another story which has emerged from history. That in 1890 to 93, there was a pandemic of Russian flu. It was called Russian flu. Of course, nobody really knew whether it was caused by flu, but the pandemic killed 1 million people worldwide. And a contemporary observer of that pandemic was Robert Crichton. And in his book, The History of Epidemics, which he wrote in 1894, he noted that unlike previous pandemics, the disease continued through 3 successive seasons of differing severity. He noted, and I quote, that the catarrhal symptoms, although not wanting, were soon found to be unimportant beside the nameless misery, frustration, and ensuing weakness. Some contended the disease was not influenza. An interesting hypothesis. And this paper in 2005 suggested the possibility, and it is only a possibility, that that influenza outbreak, which had some similarities with COVID-19, may have been related to a coronavirus, which we now call OC43, and circulates in human population and causes a common cold. It's found to be closely related to a bovine coronavirus, and by doing these same molecular clock analysis, looking at the divergence of human and bovine viruses, it's been suggested that the common source of those viruses may have been around 1890. Well, we'll never know, because there is an alternative hypothesis and data to support it, that this might have been due to an H3 influenza pandemic. But nevertheless, it's of interest that we often don't really know the causes of historical pandemics and outbreaks. And it's only the molecular methods we have nowadays that are helping us to really unpick what we've observed over many years. Now, here's the coronavirus family. Coronavirus family is really very common in causing respiratory and intestinal illnesses in human and animals, generally causes mild colds in people. And the coronavirus in humans, there are 7 coronaviruses known in humans, and the 4 at the bottom, including OC43, usually cause mild respiratory illnesses. The 3 that have emerged in this century, MERS-CoV, SARS-CoV, the one that causes SARS in 2002, and SARS-CoV-2 have been identified in recent years. Now, why did SARS-CoV spread so fast in human populations? What was its ecological niche? Well, it was introduced to an entirely susceptible population. It was shed from respiratory droplets, so easy to spread. It's got a short incubation period, so that allows for rapid spread, and a long infectious period, or longish for a respiratory disease, again allowing it to have a high R number. It's infectious before symptoms occur in the human host, which we now know, again allowing for hidden infection. We now know the duration of immunity is variable and uncertain. We're now seeing repeated infection, and it has unpredictable and variable clinical outcomes. And it emerged in exactly the kind of place that a respiratory virus likes to get around, a highly densely populated city with a high R0, remember, of 3. But it transmits in crowded indoor environments, winter emergence, and we had this extent and speed of global travel, which we recognise that a lot of hidden infection in fact got around the world very fast before we recognised what had happened. And I think that's been familiar in all 3 pandemics that I have studied. And here we are in February 22. Here's the WHO dashboard. And here you can see the waves of the pandemic going back to 2020. Now, obviously, there wasn't much testing starting in the first year or so, but now testing is widely available. You can see that although we have all now got access in this country to vaccines, and vaccines have made a big difference to deaths, as I shall show you, really we are now in the midst of the highest rates of infection that we've seen during the course of the pandemic. So how have we adapted to this virus? And how has the virus evolved? Just remind you of the interaction between behaviour and biology. Well, we know in real time, it's extraordinary how we are watching the evolution of this virus in real time, something we've never really done, I think, for any other pandemic. Here's the family tree, if you like, of Omicron and its transmission around the world. And this amazing study, the GISAID study, gathers viruses from around the world and sequences them to understand their sequences. Now, they are largely from Europe and the Americas, and viruses from Africa and so on are unfortunately underrepresented. But I think this shows you the speed of the evolution of the virus and how we have had, in red, the alpha variant, which spread rapidly and was then replaced by the Delta variant in turquoise there, and now the variant we're all familiar with, Omicron variant. Now, we have been adapting by reducing our contact numbers, as you've seen. The virus has been adapting by increasing its transmissibility, or rather, viruses that have increased transmissibility will have a selective advantage. because they will have a higher R number. So very rapidly this virus has evolved through selective pressure to select, or the selective advantage of more transmissible variants. And you can see how rapidly they've been replaced. Now this last variant, Omicron, we now know has emerged here, at least in a vaccinated population, but there are reasons biologically and from epidemiological studies that give evidence that it is also a virus which is less pathogenic than some of the earlier variants. So we're right in the midst of watching this emerge in real time. If we return to the UK, 17 million people have now been reported as confirmed cases, and we know we don't identify them all, so it'll be more than that, and over 150,000 deaths. But if we look at the ratio of cases now to deaths, that has been totally changed. And you can see there the start of the vaccine rollout. Just after that, we saw the many deaths at the beginning of last year. And these vaccines, by building immunity to disease in the population, have had a really major impact on our biological response to this virus and greatly reduced the mortality and the severe disease from this infection. But if we look at our antibody levels, and this is data from the wonderful ONS survey, a sample of people in the population, you can see by age group the rapidly rising rates of antibody protection in the population to well over 90% in adults. Now, most of this is vaccine-derived, and you can see in the shape of the curves is different for each age group, with the over 80s who are vaccinated first reaching high levels first. But in the 16 to 24-year-olds who are vaccinated later, you can see that they already had quite a lot of antibody before they were had access to vaccine, and some of this, of course, is natural infection. So we must remember that our immunity is being built up not just by the virus, not just by vaccines, but also by the virus. But we must also remember, when we return to socioeconomic conditions, that age-standardized mortality rates for deaths to COVID show that these are very variable according to deprivation decile. A lot of these are the deaths occurring before the availability of the vaccine program. And so what we see is that in the most deprived decile on the left, death rates, age-standardized death rates, were three or more times higher than those in the least deprived decile. Why should that be the case? Because we know that health determinants are very unequally distributed in the population, such that we have massive health inequalities. And those in the most disadvantaged decile, of course, have different exposures due to inability to work at home, other comorbidities, have a higher risk of other diseases, and also possibly less good access to healthcare. And all these things are contributing to the considerable inequalities in health outcomes for COVID. And also in relation to vaccine hesitancy and our ability to communicate and work with communities has shown wide geographic variation in the percentage of adults reporting vaccine hesitancy, with higher rates of vaccine hesitancy in some parts of the country, notably in London, and also amongst young adults, some ethnic minority communities, and most deprived sectors of the population. So when we think about addressing COVID, or we think about addressing infectious diseases, we can't do so without considering the socioeconomic determinants of infection. That's a national problem, and it's an international problem. Internationally, 60% of the world have had at least one dose of vaccine, but only 9% of people in low-income countries have had at least one dose. What do we need to work on? Supply, cost and financing, cold chains, manufacturing capability, which is not available in many parts of the world, and the healthcare delivery systems to do them, and of course universal health coverage, alongside public understanding, trust and hesitancy. There's a great deal to do. And of course it is not just the biological interventions we have to think of, but the behavioural ones to minimise pandemic harm, And in the long run, we have to reduce opportunities for zoonotic infections, prevent the spread of infection initially, the spread within and between communities, build resilient public health systems, and minimise the exacerbation of inequalities. So how have we adapted as a population to protect ourselves? Well, here you can see, in relation to the biology of transmission, that vaccination is very protective. We know it's protective from disease, but it also protects us from transmission. So these are data from the ONS survey, and anything to the left of the line indicates any of these dots to the left of the line indicate that you have a reduced risk of becoming infected, and these are all the different dosing schedules, but you can see they're all to the left, so anyone who's had at least one corona vaccine were less likely to test positive, as indeed with those with prior infection, which is also delivering immunity. But at the same time, of course, behaviour will also affect our transmission risk, and those who spent more time socialising with others are more likely to test positive for coronavirus back in November. And we as a society, although we may not think so, and we're all very keen to get back to the real world, and it's really lovely to see you all here today, you are still quite nicely spaced, and you are all thinking very carefully about your risk, I think. So the mean number of contacts we have is still well below pre-pandemic levels, and a face mask wearing, although it has varied according to whether regulations have been in place, still remain high. So future impacts will depend on the things that are going to drive up transmission and the things that are driving them down. We've got higher infectivity of Omicron, increasing rates of reinfections that will drive up the rate of infection. The latest data today suggests infection rates are not going down anymore and may be possibly tipping up a bit in some places. Waning immunity in vaccinated older cohorts, high levels of transmission amongst school children at present, and a general increase in contact rates. But on the other hand, in this balance of where we are now, we've got plenty that's reducing transmission, vaccination and boosters, immunity from natural infection, and of course maintaining home working to some extent. And contact patterns haven't yet returned to pre-pandemic levels. Disease outcomes, on the other hand, are much reduced by vaccines and natural infections, but we have the possible threat of a new variant or waning immunity and immune escape. So in recovering from this pandemic and moving forward, we have to think beyond, we have to think clearly about the importance of getting vaccines to everyone, but we have to also think about behaviours and environments and the wider health and well-being impacts of the pandemic. We need to build global health security, and the G700-day mission addressed just this question of trying to develop a global mission for vaccines, therapeutics and diagnostics to be developed in the face of future threats. And surveillance and early warning systems need building worldwide, not just in humans, but also in animals. We need to address clinical trial capability and equitable vaccine delivery, and the World Health Assembly are also looking at their own accord on pandemic prevention and response. If that were not enough, we don't just have to worry about pandemics, and without depressing you too much, we should remind you that in 1945, in his Nobel lecture, Alexander Fleming warned of the emergence of a resistance to penicillin and generally to antimicrobials. And this recent report in The Lancet in January this year reported that nearly 5 million deaths attributable worldwide to bacterial antimicrobial resistance. We're changing the environments that we live in, and the Lancet countdown on health and climate change highlighted the changing environments which can facilitate the spread of infectious diseases, for example, vector-borne diseases like dengue and malaria, and change the quality of water through which, for example, Vibrio cholera is transmitted. So we cannot think about pandemics in the future, we cannot think about infectious diseases without considering the wider environment. So let me take you back to the beginning and summarise that we will continue to there will continue to be outbreaks, pandemics and epidemics that sweep through human societies, often initially derived from human-animal interfaces. The nature and magnitude of those pandemics will depend on the worlds in which they emerge and the ecological niche they come to occupy. This in turn determines their success of pathogens, their success or failure in terms of human spread. Our success or failure in preventing, mitigating and ending them will in turn depend on our collective efforts to build more resilient environments, improve our global early detection and response systems, enhance capability to cooperate internationally, build the science base to create technical solutions, and beyond that, the capability to manufacture them and deliver them equitably to the world. But alongside these apparent magic technological bullets, the response of the public in instituting and maintaining individual and collective behaviour change and uptake of interventions, alongside the support and the environments to enable those changes, will remain critical. None of these interventions will be perfect, but the collective impact of multiple interventions with modest effects applied at scale can make very big differences to ultimate public health outcomes. Thank you.
Thanks for joining us. Yeah. Well, I think you can tell from the applause how wonderful that was. Thank you very much indeed. I mean, it was absolutely fascinating to hear about those different pathogens and also the way that epidemiology has changed over the course of your career and the new scientific advances that we now have at our disposal. And we are going to open up to questions from the audience. So we have a couple of roving microphones. But while you're thinking about your questions, maybe if you do want to ask a question, put your hand up and a roving microphone will appear. I wonder if I could ask you a couple of my own.
Yes.
I mean, so much of what you were talking about has this kind of humanist foundation to it in terms of a scientific, rational approach to a challenge that we're facing, but also issues that are really staring us in the face now in terms of inequality, which you brought out, especially in terms of COVID. And I wonder how you feel about, big question to start with, how do you feel about humanity facing these diseases at the moment? Have the experiences over your career and perhaps over the last couple of years with COVID given you grounds for optimism about our ability to tackle inequality in our societies, but also our ability to work globally to tackle these challenges?
I think it's a very important question. I think really what COVID has done has highlighted inequalities that have been existing for years. And actually, all the evidence is, prior to COVID, that inequalities in this country, and we know there are huge inequalities globally, but just let's stay with the UK, have been widening. And so there are, in certain sectors, you know, the rise in life expectancy has levelled off. In some areas, there's some evidence it may be declining. So those gaps have been opening up. And COVID has absolutely thrown a spotlight on that. We absolutely have to do something about this. And that has to go beyond, it has to go beyond medical services. I mean, we know that people's education experience, their work experience, their childhood experience is particularly important in what their life expectancy will be, and we've known that for many years. What we haven't been nearly good enough at is addressing those inequalities. In fact, over the last 10 years, we have disinvested in public health, and a lot of the changes that can be made are often at the local level, working with local communities, and we've actually also disinvested in local communities and in local authorities. But beyond that, we have to think a great deal about, you know, educational opportunities, work opportunities, and the very big geographical differences in health expectation, health life expectancy around the country, and health outcomes, and the quality of life. Yeah.
No, it's interesting, isn't it, when you're framing it both at a kind of national level and looking at the health inequalities that exist within a nation like the UK, but also that stark slide when you're looking at vaccine distribution around the world, which is just so shocking when you see Africa in the middle and most of the rest of the world going towards a much greener phase of vaccination.
Yeah. And I don't know how many of you saw the Panorama programme the other night, but it was really terrible to see what people were facing in terms of not being able to get vaccines in parts of the world and still with very limited health services. And you have to remember that these are the health services in sub-Saharan Africa, and I have done some work there, are already very stretched by high rates of HIV, very stretched by malaria, childhood diseases caused in many places due to those environments, like the lack of water and sanitation, which we have taken for granted here, since the 19th century. And these are really big challenges for us globally. And alongside that, you can see that, for example, the climate change examples that I gave, the relationship between climate change and health and the health consequences are increasingly recognised, but they will fall very much more intensely on people living in low and middle income countries.
Yeah. So are you broadly optimistic about the direction of travel? Do you think that we can do? I mean, I think probably we can, but are we going to do this? Are we going to tackle these inequalities?
Well, I mean, I think it's good. In this country, I really think we have to. I mean, there's a lot being said about levelling up, but we really have to see that is not just about economic levelling up that you hope will trickle down, but actually active investment in trying to act on those things which we know give people unequal health outcomes, and actually look at this through a health lens as an economic lens, recognising that it isn't a choice between health and the economy. A healthy society produces a healthy economy and vice versa. And I think we have to change the framing of how we think about that and make those investments. But that's a big policy call as well.
It is. I mean, it almost feels like we need a new rights revolution. That we've had all of these rights revolutions over the last couple of 100 years, many of them spearheaded or at least gaining momentum from humanism as well. The idea that we shouldn't enslave people, the idea that women should have equal rights with men, the idea that children have rights. And perhaps we're now facing this kind of stark reality where we need to expand those rights in a way that makes people socioeconomically much more on a level, and in terms of health much more on a level.
Yes, and I think if you go back to the Beveridge report, which really it was the beginnings of the welfare state, which recognised the immense inequalities and the poverty that people suffered. But we only need to put on the news every evening to see that people are really struggling now with rising energy bills and some without jobs. The food banks are full. These are these are fundamental rights of people to food and food and shelter. And at the same time, we have these other big challenges like decarbonisation and how we also deal with the environments in which we live globally to avoid a whole lot of quite serious impacts from climate change and so on. Yeah.
Thank you. Right, let's go to some questions from the audience. I think we've got a question just there in the second row.
Hello, can you hear me? Oh,
yes.
I wasn't sure through the mask. Thank you, Professor. Such a good lecture. That was really educational and really fantastic to see. I work in sort of social change, behaviour change, and also worked a little bit on the COVAX initiative, looking at how to get vaccines to low-income countries and public opinion towards our own level of COVID-19 and levels around the world. So very interesting to see. My two observations that really struck me from your talk, one is this equilibrium between risk and social contact, and whether that means that actually levels won't go down over time because we just adjust to maintain the same level of cases potentially. That's one open question, and the other question is the in line with the same question, the number you had about asymptomatic influenza, so my question is, from those two observations, is monitoring the number of cases going to be as relevant going forward into the next phase of the pandemic if we're saying there is always asymptomatic cases and society kind of adjusts back to, as the risk goes down, are we always going to have these cases, and is that, long term, is that just a reality, or is that a problem?
It's quite interesting because that's a kind of a question about where we're going over the next few months, over the next year.
Unfortunately, I can't hear the microphone's slightly distorted, but I think you asked about, do we always just end up getting back to the same risk level? Is that that was the question, wasn't it? Yeah. Well, I mean, this is what we're balancing out now, isn't it? Now, so what we're doing now is we're actually accepting there are about 1,800 deaths each week. Now, you can argue about whether they're all, attributable to COVID or, but that aside, there are 1,800 deaths occurring and millions of cases. But of course, a lot of people are getting infected, but they're having very mild disease. So these are quite difficult risk balances about the risk we're prepared to take, because we don't normally worry each year about getting flu. We accept we're going to get flu, and we don't go around testing people for flu and isolating them. So to some extent, this does depend on the balance of risk of getting a disease and how likely you are to get sick, and we're all weighing that up against the risk of what you have to forgo in order to not be exposed to that risk. And you can see that for HIV. I mean, people like their sexual relationships. They're part of humanity. We wouldn't be here without them. And so of course, you can see that people are balancing the risk of disease against the opportunities available to them. And I expect you probably all of you made a risk assessment to come tonight. There aren't as many people as normally come because you've made different risk assessments, and a lot of work has been done to keep you as COVID safe as possible. But those are the risk judgments we're always making. I think one of the difficulties going forward is that at times like this, when the pandemic is absolutely upon us, and we all would love to get away from it. I would love not to be asked these questions all the time because they're very difficult to answer. So we all want to get away from it. But when we do get away from it, the chances are we'll forget about it. And we won't put in place, the resilient mechanisms that we're all asking for now, because there are always competing priorities. So we always, as human beings, I don't know if humanists discuss this, but what are we prepared to make in big investments for the future against the rapid payback we get for now? And climate change is the classic example. Are we prepared now to put energy, money, and maybe alter our own lifestyles for a better environment, for a gain which isn't visible now, but yet we know we're stacking up trouble for the future? And in a way, that's the same issue in relation to investing now in pandemic preparedness for the future. So will we go on doing it? I don't know. I won't be here in 40 years' time to look back and see what did happen.
I mean, it seems at the moment that we're dropping some of those behavioural adaptations, although it's, it's great to see everybody wearing masks tonight, and we're just taking off our masks while we're speaking, and then we'll put them back on again. But it does seem that we're kind of rolling those back and kind of relying on the biological interventions that we've put in place.
Yes.
Is that going to be enough to manage this pandemic in the future?
Well, the other question is, and what I was trying to point out with the measles story, is we are going through that measles epidemic. We're seeing a virus which has been introduced into a population for the first time, and there's a lot we don't know about it. Now, if, and it's a big if, it becomes to behave like other respiratory viruses, then we will build two forms of immunity. Our own immunity and the immunity from infection. And eventually we may decide, well, over time, there will be a generation of children who will become infected as we did with flu early in life, and hoping it doesn't cause long-term sequelae, which we don't know. You will build your immunity in childhood, and the argument will be that it will become like any other respiratory infection. You build immunity in childhood, you're constantly getting top-ups, as you saw from flu. People get topped up with their flu immunity without knowing they've had flu, and it will behave like other respiratory viruses. But I can't tell you now if that is going to be how it plays out, or if we'll see new variants that behave differently. But on the other hand, we can't really go on shutting ourselves away forever, given that we can now all see that the risk of infection is very much lower with vaccination and with new variants than it was 2 years ago. But that doesn't mean that isn't going to change. And that is the challenge as a society and as individuals in the decisions we make.
And of course it is tricky with the level of vaccination being so variable around the world, that we've got large pools of a virus where we're more likely to get new variants emerging.
Yes, and yet, of course, you know, at least one of the variants emerged here where there was quite a lot of vaccination. I mean, there's a lot of discussion about where variants may or may not come from. But we also have to consider as a society the damage the pandemic does collaterally, because we've got a generation of children who were isolated at home, who've had their education disrupted, and there are huge inequalities in that. There's a big difference if there are 3 computers in a house and 1 iPhone for everybody to share to do their homework on. So there were tremendous social disadvantages distributed very differently, including your ability to go outside when it was, you know, when we were all locked up. I mean, all these things that people didn't have access to. So we cannot measure this simply on the impact of the direct impact of the virus, but also on the indirect impacts.
Yeah. And of course that disruption to education is still happening, and there was a very obvious disruption that everybody knew about during those lockdowns when schools were closed completely apart from to key workers. But there is huge rates of absences right now with the level of COVID that we've got in schools, and children being at home for long periods of time.
And that's the issue about when we have other viruses going around like flu, which we know kills thousands of people when we have an outbreak, it does kill thousands of people, mostly the most vulnerable people, despite vaccination. We get many, in fact, flu vaccines aren't really as effective as the COVID vaccines in many years. So we accept that. We don't test people for flu. We don't ask them to self-isolate. I hope people will learn more the importance of being careful with respiratory viruses when they're sick. We'll have to see whether or not people go on mask wearing and staying home when they're sick with whatever virus. But we don't test for flu. So, you know, how long do we go on testing the asymptomatic and so on? That has to be balanced against the damage, the risk of disease from the virus as well. But equally, we could learn from this that we could test for more viruses and then use antivirals for flu more effective if we had testing for other infections. So that's the upside of the pandemic. We've got much better diagnostics.
And over the last couple of years, we've done incredibly well at squashing flu.
Yes.
Completely.
Yes.
Yeah.
But it might come back with a vengeance because we've now all reduced our immunity, if you think of that slide.
Oh, no,
so let's not worry. There's anything more to worry about.
Another question from the audience then? Have we got somebody else?
Hi, you've made quite a lot of comments on the socio-economic deprivation that has possibly contributed to the high levels that we've got in certain areas of the country. Work was done on this by Professor Michael Marmot at UCL, looking at socio-economic deprivation and health outcomes. Way back in the day, he was asked to do it by Tony Blair, and he's since done an updated report, both of which have been ignored. And I'm just wondering if there's any good could come from a joint working showing that socio-economic deprivation has contributed to the outcomes of this COVID-19 pandemic.
Did you say other pieces of work? Or
No, if there will be a piece of work, collaboration, to try and make the powers that be understand that social deprivation has a big effect, and particularly with COVID.
So I think there has been a very important piece of work published, which Michael Marmot did with the Health Foundation. I don't know if you've seen that. talking about exactly what you said. I mean, I think the difficulty now is we know what these all these socioeconomic inequalities are, and we know the causes. It's really trying to get action on not describing them anymore, but actually taking action to diminish them and knowing what are the most effective ways of diminishing those. So there has been work done, and I've been involved in the Academy of Medical Sciences. We did a piece of work which is just be looked at, published soon, looking at, with the British Academy, looking at, for example, persistent geographic inequalities in relation to COVID. And I think there is increasing interest in trying to really put a spotlight on this. I've also been involved in a big piece of work looking at one of the big public health challenges of our time, which is the obesity epidemic, and the Obesity Health Alliance has very much taken a social determinants approach to the things that we need to do to reduce obesity, which is one of the, and that has many socioeconomic drivers and commercial drivers and so on, which mean we have to rethink our food system. But I think we really do need to try and garner action, exactly as you say, to take action on these inequalities. I'm sorry, I'm just got the light in my eye.
It is very bright. Thank you very much for that question. Have we got any more questions from the floor? I wonder if we've got any questions from our audience online as well. Have we got any, Jess?
None yet.
Okay, well, there's a gentleman down the front here who's got his hand up and would like to ask a question. I've got so many questions, Am.
Actually, I should also mention there's a white paper on health inequalities which was announced in the white paper that came out last week on levelling up. So that is a place to look out for what comes out of that as well.
That'll be a new one coming out soon.
Yeah.
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 Thanks very much for a really interesting talk. My question was really about the next potential pandemic. I mean, we know where there have been largely animal origins for a lot of the recent ones, as you said. Do you see any learning taking place about spotting these things very early, taking preemptive action before they get their legs going and spreading around the world?
Yeah, well, I think it's absolutely critical, isn't it? Because we know that surveillance systems are very variable around the world, and you need surveillance in animal populations as well as in human populations, and that's the One Health approach. The trouble is, an awful lot of animals out there to be looking at, but I don't think we pay nearly enough attention to that. As part of it, I show you the G7 100-day mission thing, which is very much focused on vaccines and therapeutics, but at the same time as that was published, there was also a document published by Jeremy Farrar looking at really that we need to have really good investment in global surveillance systems and early warning systems in order to pick these things up. But clearly they can arise from anywhere in the world, and there is very great variability in that. So there needs to be a global effort to try and bring these things together. I mean, let me take as for example that GISAID thing the GISAID virus sequencing. But you can see there's a lot of bias in what's in those samples because a lot of them aren't coming from low and middle income countries. So I think there are proposals afoot, but we'll have to see whether they get put in place. But even if you've got an early warning system, you then need a competent public health system to be able to take action early and try and stop these outbreaks happening in the first place. That's also critical. So that means a lot of investment in places that have very limited public health systems and very limited healthcare systems if you're going to achieve that. But it is a critical issue, yeah.
Thank you very much. There's another question just in the row behind. Oh, is there? I can't even see the upstairs. It'll be a voice from the ether.
Hi, yeah.
Hello.
Don't look up because you might be blinded. Sorry. It's a question about the emergence of the Omicron variant. And given that it's emerged during a period where travel was greatly restricted, but it seems to have emerged worldwide, how much do you think there is an impact of similar selective pressures in different countries leading to the emergence of the same variant? Or do you think it's just down to the spread of the virus through travel?
No, I think this is the spread of the virus through travel. I mean, we still move quite a lot, and it's a very infectious virus. It was picked up pretty early. I mean, there's a big discussion about its emergence, whether it may or may not be from an immunocompromised person, and as we know, there's high rates of HIV, and you can see, I mean, whether that is the origins, we don't know. That'll have to be looked into. But no, I think this is the emergence around the world of that variant. But you see, whether or not a variant spreads, there are variants emerging every day, and a lot of them never turn into anything. They have no advantage, or they may in fact be disabling to the virus. So they just, or else the person in whom they emerge never passes it on. So these are also stochastic events that whether or not one ends up causing an outbreak is also has a high element of chance involved in it. But as I understand it, this was the spread of the same, very clear, same genetic footprint around the world in that mutation. Yeah.
I mean, it is utterly extraordinary during this pandemic watching genetics in action.
I know.
And watching, the sequencing of these new variants as they pop up, and not only the sequencing, but the translation of that into knowing something about the structure of the virion, of the virus particle.
Yeah.
I mean, it's utterly mind-boggling, the science, because this hasn't happened in any previous pandemics. We haven't been able to see it happening.
But it's not just the mutation, it's also understanding what that mutation is doing at the level of the spike protein. I mean, it's way beyond my molecular biology competence. But, it's absolutely fascinating where they can look at what the structural effects of these are. But going back, I mean, you realise going back to the HIV pandemic, never mind 2 weeks to find the virus, it was a difficult virus to find, it was a retrovirus, but it took 2 years to find it, and another 2 years to have an antibody test. And this has been unbelievable. Yeah. And there's no vaccine, much more difficult thing to develop a vaccine for, but it has been very fortunate that this was we had the technologies for these vaccines, but also it was a virus to which it was possible to produce a vaccine. We have done it, and I think really the efficacy of these vaccines was much greater than anybody could have dared to have hoped when the vaccine trials were started.
Yeah,
so we
that
have
is astonishing.
a tremendous debt to those who have developed those vaccines. Yeah.
I mean, that gives me grounds for optimism about COVID, but also about future pandemics, that kind of ability to work together, for scientists to work together globally. Yeah. And I kind of had this impression of a world which is actually still quite divided and still quite medieval in many ways, with people pulling up drawbridges and jealously guarding resources, but the scientists working outside of that and collaborating globally.
I mean, that has been extraordinary. And, having worked with a lot of my colleagues at the Academy of Medical Sciences, a lot of whom have been involved with SAGE and so on, people have worked 24/7. And they've worked across disciplines. And that kind of team science approach has been very important, because I really wanted to emphasise to you here that if we want to understand the whole, you have to bring a lot of different disciplines to bear, from the molecular biology through to the social science and the psychology and the economics and how we deliver health services. That's all been part of the mix. I mean, what have we done as human beings is another interesting question. I mean, you can remember, I think the first lockdown, there was a great sense of solidarity alongside that uncertainty. Whether that has really been sustained, I think is more difficult to say. I'd be interested to hear what you feel about that.
I think it's variable. I think that, it seems to be different in different communities, doesn't it? But I hope there is still some of that. I hope that seeds have been sown and it will persist.
And I think that's another big area which we talked about when I was involved in the winter reports, warning of what might happen in winter and things needed to be done. And we realised that there were many different publics out there, many different communities that were not, and the communication between science and some of those communities has been suboptimal in how we've been able to engage with different communities. We've worked with some wonderful young people who talk to us. We developed in the Academy developed a comic program with some young people internationally, and they were very moving about the pandemic, saying how they had felt quite excluded sometimes, because, you know, it was seen as a problem for the most vulnerable, and yet they were having real impacts on their lives at a time when it's a time for exploration and getting out and meeting people, and all the things that are so important about your teenage years and your early 20s and also being a kid. You know, I've been withdrawn from you, and that's really tough. And that's an effect of the virus, but it's an indirect one, not a direct one.
Yeah, it's really difficult, isn't it? I mean, I think that when we think about vaccination programs, we have some vaccination programs where people are vaccinated to achieve herd immunity through the population, and actually the most beneficial effects of that might not be for those individuals. And I'm thinking particularly of things like rubella, where we're immunising young men and boys against rubella, largely to protect pregnant women.
Yes.
And I feel in a similar way with COVID over the past couple of years, in terms of the collateral damage to people's lives has mostly affected those people who were least affected by the virus in a way. So people who were sort of in their teens, 20s, 30s, maybe.
But there's a lot of collateral damage for older people in terms of access to healthcare, and that's also very unequal because, of course, it's people with chronic diseases and on waiting lists who have been, you know, not been able to get those things, and that not having being able to get your hip operation done, and if you're self-employed, may mean you can't work.
Yeah.
So I think a lot of older people have also really suffered collateral damage in different ways, not to mention social isolation and poverty. Yeah.
Let's take some more questions from the audience. There's somebody down here in the second row.
We do have an online one.
Oh, do we?
Now, in the spirit of being fair. So it's, should we be worried about the new HIV variant found in the Netherlands?
Oh, a new HIV
variant. Do you know, I'm afraid I'll have to pass on that one.
That's okay.
I'm a very sorry person online, because that seems a shame that somebody online, I'm afraid I've got distracted by COVID, I think.
There's a question from somebody in the second row of the audience here, and I think, actually, that's going to have to be the last question of the evening. We could carry on chatting for ages, but we are going to have to wrap up soon.
Thank you for fitting me in. I was just curious about all the ways we cause problems for ourselves without the help of a pathogen. So health impacts like generating pollution and air pollution, water pollution, microplastics. We're quite good at generating problems for ourselves. And I was wondering, you know, there's all these, society gets more and more complicated. There's more and more problems that we're generating. And I was just wondering whether you see any joined up thinking. I mean, there's a lot of problems ultimately caused by there being a lot of people in a complicated society. Do you see sort of joined up things that might solve all of these problems, or attempting to, or is it all just, we'll take one problem at a time because it's all we can cope with because that's hard enough?
Well, that's a very big question. I'll probably give you a very small answer. It seems to me that there are common causes of all these things. I mean, you know, I was trying to sort of point out why, well, we've always been at risk of a pandemic, but this pandemic has spread with unbelievable speed because we mix with each other at very fast rates, so that, you know, if you read some infectious disease epidemiology, historically, things happen much more slowly because population sizes were smaller, there was less mixing. So the way we live, of course, is contributing to the risk of pandemics, and that includes, as I said, these animal-human interactions, environmental degradation, all these deforestation, which changes the ecology of how we contact animals. I mean, these are all part of the same issue. So really you have to go back to the whole global sustainability agenda, and a major part of that is, of course, decarbonisation. But it's also, I think, invested broadly or conceptualised in the notion of planetary health. I don't know if you've come across that idea, but that we, in order to have a healthy human society, we need to have a healthy planet in all the ways that it's described, all the ways we can do that through working towards reducing degradation of the kinds of things you're talking about, whether it be microplastics or cutting down rainforest, and all the many issues we're having to deal with, and of course our growing carbon emissions. And if you conceptualize that everything we should do should be towards that mission of increasing planetary health and repairing the ecology that I was trying to talk about, or the ecological imbalances, then I think that concept does try to bring it together, but it doesn't give you one single solution. It's multiple interventions, each with a small effect, as I said, but with the same goal of trying to diminish the damage we create to planetary health, I guess.
That's a wonderful question to finish on. I think that is Helen, isn't it? Lovely to have you here, Helen Chersey, who is a brilliant physicist and a Christmas lecturer as well, who spoke about planetary health in those lectures very eloquently. And I think that question is a wonderful place to end, because it picks up so many of the themes that you spoke about in terms of bringing different sciences together to bear on the challenges that we're facing, and not just sciences, but to think about the environment more broadly, and to think about our society more broadly as well. Thank you very much for an absolutely wonderful lecture.
Thank you for inviting me.
Thank you. And I'm just going to stop you there, because I want you to save your applause for the presentation of our Darwin Day medal to Dame Anne Johnson. Thank you very much for that absolutely wonderful lecture on Darwin Day 2002, and please accept that from Humanists UK.
Thank you very much. Thank you. That's really lovely. That's fantastic. I'm really delighted.
Thank you very much. It's wonderful.
Thank you. Thank you very much.
So thank you very much, everybody, for coming out this evening and for joining us online as well, or watching on catch-up even. Our next planned event is the Rosalind Franklin Lecture, and I'm very excited to be the first to announce that the speaker is broadcaster and space scientist Maggie Adderin-Pocock, and she'll be speaking on the 10th of March, and the tickets will be going on sale for that very soon on the Humanists UK website, which I'm sure you're all very familiar with. Thank you very much, everybody, for coming. Stay safe, keep well.